I really wanted to thank Drs. Gao, Huntsman, and Nimmo for inviting us to share a little bit about some practice updates for COVID-19, and then really some what to expect in the fall. If for those who don't know me, I'm Titus Wong. I'm a medical microbiologist and infection control physician, and my role is as a regional medical director for infection prevention and control at Coastal, and with my other hat, the medical director for the Provincial Infection Control Network at PHSA. And I'm co-presenting today with Jen.
Hi, I'm Jennifer Grant. I'm a medical microbiology and infectious diseases. I've been heavily involved in both the POSH and now MPOSH, which is an occupational health service specifically for medical practitioners. And I'm also chair of the Clinical Therapeutics Committee for BC, so that's therapeutics for COVID.
Sorry, I had the difficulty in logging in. I'm supposed to introduce both of you. Thank you both. You done your self-introduction. Thank you so much for doing this. Please go ahead. Thank you.
And thank you for the invite.
Thank you. Sorry about that.
No worries. We'll jump into it. We want to acknowledge that our work and play takes place on the ancestral and unceded territories. I'm meeting on the lands of the Musqueam, Squamish, and Tsleil-Waututh people. And if you want to recognize the lands in which you are meeting from today, please feel free to do so in the chat. Jen and I have a number of people we want to recognize, but it's a cast of thousands. I do want to point out that we received quite a lot of the slide support from Linda, Natalie, and Kwan, Jesse, James, Nuria, Romy, Joseph, and Michael Lee. So big thanks to them. Jen, I don't know if there's certain people that helped you with the slides that you want to point out.
I do really want to thank everybody in MPOSH, especially Dr. Annalie Yassi, from whom I shamelessly stole the slides, and also the entire Clinical Therapeutics Committee, which is representative of all the health authorities of BC, in particular Yolanta, who is our wonderful co-chair and pharmacist.
Awesome. And for the purposes of this presentation, neither Jen nor myself has any conflicts of interest. And our 4 objectives for today, first is really to review the current provincial COVID-19 epidemiology, and then talk a bit about some of the safety recommendations that are in place now. There's a tremendous amount of policies and orders and guidance, so we just wanted to chat about some of the highest priority ones. And then Jen's going to talk a little bit about the MPOSH and the safety, physician safety components of that. And also we'll be discussing some of the current therapeutics, for which Jen is also the chair of the COVID Clinical Therapeutics Committee. And throughout the presentation and towards the end, we'll talk about what to expect as we move towards a COVID endemic state. So this is shocking no one when I state that BC has an excellent diagnostic microsystem, and I think it's really falls into the same diagnostic excellence sphere as pathology in BC. And COVID-19 really highlighted this, and this thanks to Linda and her team for the slide. In this timeline here, you can see that within days of the Wuhan virus or SARS-CoV-2 being identified, BCDC and Mel and Linda's team really went to work developing an assay that could be spread across the province. And of course, our early uptake labs, including St. Paul's and VJ's and Children's and everywhere else across BC, we were able to diagnose COVID really within a couple weeks of the genome being released. And that's really due to the leadership from the public health lab at BCCDC. So big kudos to that team. Now, everyone is already aware of how good the diagnostic is. Okay, that's not surprising. But how did it function as we got more stressed through the pandemic? So I'll draw your attention to the top part of the top left-hand corner here. And this is really off the BCDC dashboard. And it's showing the test volumes as we move through the pandemic and hitting into those 10,000, 20,000 tests. And that's a significant amount of testing. But the incredible part of the story is that the average turnaround time for these tests really stayed under 24 hours or under, and there was a couple points in which we were stretched and maybe hit 40, 50 hours. But by and large, we experienced just this everyday excellence of diagnostic testing. And it's something that we were very, I think we got so used to it, we were blinded by how good it was. And this doesn't just happen accidentally. It took a tremendous amount of collaboration between the medical directors and the micro labs. And I could list everybody, but I think you all know who they are. And to not only adopt the assays from BCDC, but also look for new ways, whether it's multiplexing the COVID into the RSV and influenza testing, or working together as an entire system. And I think that's where I do have to call out Dave Schaefer for his leadership in coordinating at the convention center some of the lower mainland testing schemes. So that was able to, that allowed us to keep our turnaround times low. And you're saying, what's the big deal? Was it that big of an impact? What we didn't see was a lot of these stories in BC. Stories where turnaround times hit about 6-7 days. So you can see there about 4 days in Manitoba. And why that's significant is that in the early days when there wasn't a vaccine, there wasn't treatment, contact tracing was the biggest tool that we had to prevent and mitigate further spread. And being able to quickly identify and accurately and rapidly identify COVID within that 24-30 hours was instrumental in ensuring that there wasn't a massive spread across the province. Now, you can say maybe there was a lot of high turnaround times in the community, but in the States, they also saw this in some of their highest priority areas, including some of their hotspots in long-term care. And you can see that the vast majority of the results really took between 1 to 7 days, even in those high priority areas. And again, in BC, we were able to get these results in less than a day. So the backbone really of almost our entire COVID response in BC was built off of accurate rapid diagnostics. And I think that this is a point that is often overlooked. And so I really wanted to drive that home today. And the accurate rapid diagnostics gave us useful, timely surveillance for BC. And from there, we were able to craft the appropriate policies and practices to achieve good health outcomes afterwards. I think everyone's very familiar with these epi curves here. This is the new daily cases normalized across 100,000 population, 7-day moving average. And you can see here, we are really at the downturn of the latest COVID waves. Thank goodness. But you can make an argument, maybe the new testing guidelines that made testing more restrictive is responsible for this drop. Maybe it's an artifact, right? And again, commendation to Mark Romney for leading the testing guidelines committee there. this is where Natalie Prasajecki and her team comes in. So some brilliant work from the BCDC. There's a great news article about her on CTV. And I think in it, she mentioned how, what started out as a small research project 2 years ago has turned into an invaluable tool for us to monitor COVID. Essentially, is based on the principle that SARS-CoV-2 is shed in the feces of infected patients, and that these findings are independent of test seeking behaviors and test restrictions. And so does it align with what we found with the EPI curve? And absolutely it does. You can see here in Fraser as well as in VCH, the curve looks exactly the same. And so hats off to Natalie's team at BCDC. And really the next phase of it, a little bit crystal ball, is a expansion of their program to include other viruses, including influenza and RSV, as we head into the fall. So very excited to see that work. Now, certainly case counting is inevitable and something that we always do during a pandemic. But really what we need is, we need outcomes to contextualize those counts, because it wouldn't make much of a difference if the disease is not very severe. And so we look at things such as deaths as well as hospitalizations and ICU admissions along with the case counts. So BC, we're very fortunate, and despite the fact that many people experience significant loss, we had low mortality rates compared to the rest of the world. We did quite well. We could always do better, but I think by comparison, we did okay. Another outcome that we looked out for was hospitalization, and if you look at the last month or so, you say, hey, are hospitalizations increasing? Because that's what it shows. And what are some of the explanations for that? And as you can imagine, as you go further and further along in a pandemic with high infection rates, there will be more and more people that have been had prior infection. You take that understanding along with knowing that a PCR assay is going to detect COVID for quite a long time, and you can start coming up with some theories. So this is some data from both the Providence as well as Vancouver Coastal, looking at some of the incidental versus significant cases of COVID. So incidental meaning, did somebody arrive in the hospital, say with a broken ankle, and they just happen to have COVID, or maybe this is an old, a previous COVID infection that they've since recovered. Those would be incidentals, and versus significant meaning you are in the hospital or you've been admitted to hospital because or due to your COVID disease. So this is fantastic work that we worked with Michael Lee's team, and there's a cast of thousands here as always, looking at really Delta and Omicron. So Delta would be the blues, the Omicrons would be orange, and then the reds would be the subvariants from there. And by wave, you can see that in the Delta, 66% were clinically significant and warranted treatment, and about half of the Omicrons were significant. The other half of it was incidental. These findings were corroborated by the public health's own investigations on the same topic. So you can imagine that maybe this isn't quite going up by the same trajectory, but rather a little bit lower than that. Okay, this is just a methodology. The next question after that about whether or not the cases are incidentals is whether or not we're transmitting that within the hospital. This is thanks to some work from, I think Marshall Taylor did this, and it really showing that, you know, roughly 20-25% of the hospitalized cases, there's still some ongoing transmission within healthcare. And so the significance of this is that even though you come in, say you have an incidental case, you can certainly transmit it to someone else in the hospital, and then from there, that the person may be supremely vulnerable, and that could become a significant infection or event. So this is some great work from James and Linda, and thank you for the slide. Some excellent data visualization here showing us the distribution of the COVID and some of the variants and some of the subvariants. What is also great about this is it also overlays some of the major public health interventions about vaccine passports and restarts stages. And you can see that really in the last few months, the vast majority of cases have been Omicron. So we expect this trend to continue. I did have to mention that if anybody's been tracking the impact of vaccinations, that say in Delta and earlier, we really did hammer home that the vaccinations had significant impact on transmission as well as improving outcomes. Unfortunately for Omicron, the vaccines haven't shown to be as effective for transmission purposes, but are still quite effective in decreasing poor outcomes such as hospitalization and critical care. Do have to note that in Delta, these differences were more pronounced previously. And Jen reminded me, well, part of it is because a lot more people, even in the unvaccinated cohort, has now had COVID, and it does provide some measure of immunity, which was very well described by Danuta in one of her papers. I think she put this out maybe about a month ago, I want to say. And what we're seeing here is that if you had previous infection, this is the orange or brown curve here, previous infection and no vaccine, you still had, it was still has some effectiveness against prevention against reinfection with Omicron. And you can see here previous infection with one vaccine. This is the open circle graph line here. It really follows a very similar trajectory along with the previous infection in two vaccines. Now, certainly we don't know, we don't have enough data going out to take this out to anything beyond this 1 year mark. But you know, over the next 12 months, I'm excited to see an update on Danuta's data on this work. All right. So just a little bit about what are the current recommendations and safety practices in BC. I'll put on my other hat with the PHSA, with the Provincial Infection Control Network, which is a health improvement network, as a collaborative network with all of the infection control community of practice. This includes infection control practitioners and medical directors and operational directors, epidemiologists. So a lot of credit goes to this entire community of practice for some of the things I'll be talking about next. Our major pieces of work include provincial surveillance, research, and educational practice. Actually, I do want to point out Linda's my co-medical director there. And really the goals are to provide advisory to the Ministry of Health, help with strategic planning and priority setting, as well as coordinating the health system with our community of practice. I won't go through this in too much detail, but suffice it to say we were very busy during COVID, as was all the health authorities. In total, PICNET reviewed and either wrote or provided feedback on over 75 practice guidelines. And so you can imagine there's a lot of recommendations out there. I'll talk a little bit about the biggest ones. I think the first is masking and face coverings recommendations, and it really just three areas: the public, community, hospital, and long-term care. Now, this should come as no surprise. Everyone is aware that the provincial face covering order has been repealed, and it's really about personal choice. But Bonnie did say that individual businesses and institutions are still allowed to require masking, and that's up to them. In healthcare settings, medical masks are still mandatory for staff and visitors. And one of the most common questions, like, what do we do in non-clinical areas? So this guidance is not covered by the provincial face covering orders, but rather is governed by a policy, the November 2021 policy communique. And in that policy, it does say that in non-clinical areas, you can create a safety plan and deem optional masking as safe, but it requires collaboration between that section or area lead along with infection control and occupational health. Vaccinations, I think this is pretty straightforward. Vaccinations are mandatory for us and personal choice for others. And then proof of vaccination, not required in the community. However, again, very similar to the masking requirement, they are actually still allowed to require proof of vaccination, whether we agree with it or not. Individual institutions and businesses are allowed to ask for it. And in the hospital and healthcare settings, proof of vaccination is still required for visitors. Now, this is one of the, I'll jump to the future here a little bit. We have put up recommendations to the ministry to do away with proof of vaccination for visitors in healthcare settings. This has not yet been accepted. And so when that time comes, we'll certainly let everyone know. And testing, this is probably the area that's going to see the biggest difference. And I'll and somebody that's on the testing committees, whether it's Mark or Linda or Mel, might be able to comment more on this. But currently, based on the testing guidelines on the BCDC website, in the community, COVID-19 testing really is discouraged unless it impacts patient care, or you're part of certain clinically vulnerable populations, or if you work or live in a setting where others are at high risk. That includes congregate settings, long-term care, et cetera. And so in the hospital, again, testing is indicated only for patients with compatible symptoms. And then also the important part is that it impacts patient care. Isolation, I'll just keep it very brief here, which is should probably refer to your IPAC colleagues. There are some discrepancies, say in the public and the community. The current public health recommendation is that if you have a positive COVID test, then certainly you want to self-isolate at home for 5 days, as long as your symptoms have been improved and you have no fever. Now, you might say, hey, wait, hold on a second. I thought that a whole lot of people aren't going to get tested in the community. And that's true. And so there's another recommendation. If you're symptomatic but do not meet criteria to be tested, then you should stay home until you are better. There's no hard set date. In the hospital, because of the vulnerable populations, we do recommend isolation for 10 days. And sometimes it gets modified either lower or higher, depending on whether or not it's an incidental infection, as we discussed earlier, the underlying conditions for the patient, if they belong to a clinically extremely vulnerable population, or if they have a very severe disease. So with that, I'm going to hand this over to Jen. Do you want me to drive for you, or do you want to drive yourself? You're on mute, Jen.
That's how most people like to listen to me, especially my kids. I will drive. If you relinquish this screen sharing, I will scrap my machine.
Relinquish, my friend.
All right. Assuming I can figure out how to do such. There we go. All right. So what I'm going to talk to the crowd about is some of the work that we've been doing with our occupational health colleagues, specifically with something that used to be called POSH, which was Physician Occupational Safety and Health, and has now been changed to MPOSH, to acknowledge the fact that there are people who provide medical services who are in fact not physicians per se, our colleagues as midwives and nurse practitioners. So essentially, what we want to do with POSH and MPOSH is really to try and make sure that we cover people who are at a risk of occupational exposure to infections. And the problem is that this is sort of the circle in terms of exposure follow-up where everybody's around it. But unfortunately, so nurses are covered by employee safety. Public health covers the general public. Patients are covered by infection control. But unfortunately, physicians aren't actually covered by anyone. We're not employees, mostly. The present company mostly accepted. We're independent contractors. We don't have anyone who really looks after us. So we've never sort of been in anyone's radar. And we're not considered members of the public, and we have special exposure considerations. So early in the pandemic, it became very clear that this was a huge issue. And so the POSH, now MPOSH team was put together. It's a combination of physician leadership, occupational health specialists, infection prevention control, as well as the personnel actually doing the work. I just want to make a special call out to Annalie Yassi, who has been running this. She is a world leader in occupational health and has been doing this essentially, well, not completely pro bono, but essentially pro bono. We have Dr. Stan Lubin, we have Arnold Capani, and then the rest of the team taking care of the administrative and the day-to-day work. And this has been actually a really great and creative use of medical students who are being trained to do intake interviews and learn a little bit about public and occupational health, as well as earn a little bit of money while they're doing it. So in terms of getting the team together, essentially this was really about trying to fit into a system that was already fairly tightly fit. We've all worked with WorkSafe BC, the Employee Safety and Wellness, the Workplace Call Center, which is provincial, whereas the Employee Safety is local. But then we also have sort of the medical side that we're a little bit more familiar with MedMicro and public health and physicians. And these gears are sort of churning, but not engaging. And that's sort of the role of MPOSH, to bring all of these things together and to have a lens, especially for medical practitioners. And as you can see, I'm having fun learning with animations in PowerPoint. So what does MPOSH do? Really, it's sort of free form. There's an email intake that is there to answer questions and support people through occupational health issues. This was put up for COVID, but in fact is now branching out for most infectious exposures. So there to answer questions, talk about exposures when somebody found out after the fact that somebody might have been infectious and they might not have been wearing their PPE correctly, getting test results, following up, and then giving direct medical advice, because the two physicians in the group are able to do that as part of their practice. The other thing that's been really sort of important for MPOSH is collating data on safety and putting it out in real time. And all sorts of information sheets that have been circulated in the physician community, talking about the things that you might need to know, the questions that people have, the questions that are common to ask, to make sure that people are informed about what's going on. So as of May 3rd, 2022, you can see the numbers here, but essentially at 3,000 exposure risk assessments and some contact tracing, and then additional questions about other things that are pertinent, often related to family or exposures to family or risks to family. And then what we're moving into a lot now is some workplace violence issues, although that's relatively low for physicians and medical practitioners compared to other people in the healthcare system, but taking on the TB contact tracing and working with public health very closely. So just some examples, very typically for COVID has been, am I allowed to go out in the community if I've been working on the COVID ward? Or, you know, my partner, my kids, and then talking about the data behind personal protective measures. And then obviously some of the more common things are coming to the fore now, things like I've got shingles, am I allowed to go to work? How long do I have to be off? All the stuff that's associated with that. This is some of the research that's been put out. So this is part of a paper that was published in PLOS 1, essentially looking at that early vaccination period. So the vaccine campaign started in mid-December, December 15th, prioritizing healthcare workers amongst others. And as you can see, the line, these are the number of infections with the general public, and the blue line is healthcare workers. Blue line is healthcare, blue shading areas, the proportion of healthcare workers vaccinated versus general public. And as you can see, as that vaccine campaign happened, despite the fact that there was a spike in general cases in the community, healthcare workers were actually quite well protected by vaccination. So the service has really been built on the values of protecting the worker and taking workers' rights as the sort of #1 concern. The aim during sort of the worst was to be able to answer within 2 hours. That's not sustainable and probably not necessary when we're talking about things like tuberculosis, where you've got quite a while to respond. But to really have the expertise available and people who are physicians who can answer physicians' questions, because I think many of us have had the sort of frustration of knowing the basics and needing to ask a very much more in-depth question and talking to somebody who doesn't have the expertise to answer it. And really also working on advocacy. So people who've had specific issues, either related to vaccination or others, to advocate for that person, even if it may not be necessarily aligned with current recommendations, but really trying to work with the system to help support people the best possible. Also, I know this is a big concern. The aim is to be confidential. And I think part of the issue is historically, especially with infectious exposures, has been that usually what happens is somebody gets exposed by accident, either because they intubate somebody who's crashing or somebody did an autopsy and we find out after the fact that there was meningitis. Those are just some examples. And there was historically no one to go to who could prescribe the prophylaxis, and then you had to reveal medical information about yourself to your colleagues. And the aim is to avoid having to do that. People don't want to tell each other if they're pregnant or if they have immune compromised or whatever it is. And so making sure that that's in an independent body that doesn't report to anybody we're reporting to. And again, it's all optional. No one's going to force this down anybody's throat. So really it's about collaboration and trying to fit into the system. And we are actually working heavily with Doctors of BC to try and come up with something sustainable and funded, not just for Vancouver Coastal, but for the whole province. And so there's a gap analysis review that's actually been done. And the PIMSEC working group is actually trying to put a provincial model together and trying to get it integrated into existing systems. So this can sort of be run on the road, and this will be a service, hopefully, that will be available for the long run. So that was what I was going to talk about MPOSH, and I think we'll just take questions at the end, because the other thing that I wanted to talk about is COVID-19 therapies, because this is something that we're dealing a lot with, and it really actually has been a bit of a game changer throughout the pandemic as we've learned more and more about the disease. So this is available if you just Google COVID therapy, BCCDC, you'll come across a webpage. This is the sort of main document. I'm going to break it down just a little bit, not in great detail, because I don't think most people here are treating COVID patients, but it does actually speak to the pathophysiology and is actually important in our understanding of the disease as well. So the Clinical Therapeutics Committee, we have a PharmD chair and an MD chair. I am the MD chair, and Jolanta Pusix is the PharmD chair. We have representation from all of the different health authorities. We also have representation from the affected specialty groups. So general medicine, family practice, hospitalists, intensive care, rheumatology, infectious diseases, medical microbiology, hematology, pharmacy. Everyone who has a stake is at the table and able to sort of comment on the therapeutics. And as Titus was saying, our testing policy has changed because right now we accept that this is an endemic virus. This is a virus that will continue to circulate for the foreseeable future. We will all be infected, and we will probably be infected semi-annually or so if it's going to follow the pattern of the other coronaviruses. So we don't, it's not so important that we know that somebody's infected. We want to know somebody who's infected, who's at high risk of some sort of an outcome, such as going to hospital or needing the intensive care unit. And so we're trying to get to those people and get therapeutics to them. So the aim now is test to treat. So now we're testing people who have symptoms so that we can patch them into the system as needed, either through their family physician or through hospital or other outpatient therapies. If you look at COVID sort of writ large, there's sort of divergent pathophysiologies. In the very early phase, much is attributable to viral invasion, and that's where antiviral therapies are most useful. I'm going to get to those in a bit. But very early in the pandemic, it became quite clear that, in fact, the very severe disease had much more to do with immune dysregulation than it did with direct viral invasion. In fact, people would get the virus, get better, and then have basically a catastrophic immune cascade. And so the treatments that have come out from that are essentially mostly immune suppression. So what you can see for those in critical care, we use steroids or IL-6 or JAK1 inhibitors. And the other thing was massive coagulation cascade dysregulation. And so using anticoagulation strategically has been shown to be quite helpful. But the timing of that is actually critical. And trying to get that right at the time you're getting into critical care rather than waiting for too long, because once that pathophysiology has been set up, it's actually hard for it to stop. The same is true of severe disease. And again, severe disease spans the time period between when antivirals might have some use and when immune modulation is the most important. And really the backbone is immune modulation, but there is some evidence that some of the antiviral medications may have some benefit, although the benefit is small and much more effective when done earlier in disease. Speaking of earlier in disease, so what we want to get, what we're sort of really aiming for now in the community is to identify those people who are at high risk of severe outcomes. And the people at highest risk of severe outcomes of those members of our community who are what we call clinically extremely vulnerable. So these are people, they are broken down into three major categories: EV1, 2, and 3. CEV1 are our active chemotherapy, bone marrow transplant, and solid organ transplant patients. These are people whose immune systems are severely compromised. CEV2 are those people on high dose immunosuppressants, specific immune blockers, et cetera. And then CEV3 are people who are have multiple comorbidities or specific comorbidities like cystic fibrosis, like pulmonary fibrosis, where any derangement in lung function would be quite catastrophic. And these are the people who are at the highest risk of hospitalization. And you can see they're broken down not only by what their category is, but how many doses of vaccine they've had. So no doses in 70 plus, exceedingly high risk of hospitalization, down to 18 to 49 with 3 doses, the risk is quite low. And in fact, like everywhere else, age is just a huge, huge, huge factor, regardless of what your underlying disease is. If we look at this is the high risk population, but looking at the very general population, if you are otherwise quite healthy and relatively young, your risk of severe disease is actually quite low. And this is specific for Omicron, which we know is a much lower risk variant. As you can see, as your age goes up, as your number of comorbid conditions go up, your risk of hospitalization goes up. Using these data, which come from the BC CDC, this is how we've targeted the outpatient therapies. We want to get antiviral therapy into people who are in this, certainly in this category, and then in some of these categories. And so we've created a point system, and the point system allows us, when somebody tests positive, to know whether or not they benefit from therapy. And really, essentially, we're giving points for age, vaccine status, and then at-risk conditions. And based on this, for those 5 and 6 points, we strongly recommend therapy, either oral Paxlovid or IV remdesivir. 3 and 4, the risk benefit is less clear with the medications. Some people might choose to take the medication, some might not. And so this is a sort of a situation where patients' values and preferences are considered. So 3 points or less, you get chicken soup. 4 points, you could consider oral medication if you're able to take it. We would not recommend IV therapy for this group of people because the risk benefit is probably not there. But once you get into the 5 and 6 range, we still want to recommend the oral medication, which is Paxlovid. It's easier to take. It doesn't require 3 visits to hospital with an IV. And it's just maybe just a little bit more effective, although it's never been compared head to head. But if you don't qualify for that, then we would give you IV therapy. Then the last thing I wanted to talk about is something that's sort of hot on the presses, and it's a drug that is called, and I can never get this right, Siglavimab Tixivimab. It's 2 monoclonal antibodies in the same bottle, and everyone calls it Evusheld because there's too many X's. It's a monoclonal antibody that's been heavily modified. It was based on the original strain and hasn't been changed since. And it was tested, and the clinical trial just came out very recently on unvaccinated high-risk people. And this and the aim was for it to prevent hospitalizations. But what they actually tested was symptomatic disease. So here you can see, this is from the paper that was published in the New England Journal, and they do show quite a good hazard ratio with placebo being a higher rate of symptomatic disease than treatment. But if you actually put that on a real scale, this is what it actually looks in terms of absolute risk reduction. And so, you know, and this is for the endpoint of symptomatic disease, not the endpoint of hospitalization, which we're not actually trying to prevent. We are trying to prevent that hospitalization. And what actually has come out from a number of studies is that there is actually a cardiac risk associated with this. These are the different studies looking at it, and you can see that the severe adverse events, these are specifically severe adverse cardiac events. When you do the meta-analysis, you actually do get a statistically significant increase in serious cardiac events, keeping in mind that that means hospitalization for a cardiac event. So it's not just increased angina, it really is severe enough to require hospitalization. And in fact, the hospitalizations for cardiac events or the severe cardiac events equal or exceed the number of hospitalizations prevented by Evusheld for COVID. So that being the case, while this has been approved by Health Canada in BC, we are really reluctant to make it widespread use. And you can see what the wording is of the recommendation from the committee. But essentially, because of the fact that they looked at the original strain, they tested it for symptomatic disease, not hospitalization, and the fact that severe cardiac events have been quite impactful and quite worrisome as a safety signal. We don't know its efficacy on current variants of interest, but we do know that that severe cardiac risk rate will remain constant. So essentially, unless there are extenuating circumstances, it's not generally recommended. And that's where I will leave it, and I will pass it back to Titus. Do you want me to drive, Titus, or do you want to?
Pass the football, Jen.
Okay.
All right, here we go. Cool. And you know what, really a big thank you to Jen for her leadership on the Clinical Therapeutics Committee, and to Dave Sweet, the chair prior to her, really informed the province and really kept a lot of people safe. And I'll have a question, Jen can think about this a little bit, but about POSH, really about you know, the big next steps provincially and how that can serve as a model for other programs. So planning into the summer and the fall, really 4 major areas: the guidelines and education, staffing and capacity building, ongoing surveillance, and PPE safety and readiness and supply chain issues. I'll talk first about staffing and capacity building. At least from the infection prevention perspective, the ministry is looking to further enhance staff IPAC staffing levels. So a new model is going to come. It'll benefit everybody. So looking to having some conversations with Susan and Victor and Jocelyn and Gada. I think there will be hopefully some good news coming soon. The other part of the capacity building is really about creating that knowledge pipeline. And so we're doing a lot of work with the Learning Hub, and also further developing the UBC IPAC infection control course that Liz Bryce and Diane Roscoe created a number of years ago. So right now, people like Shazia and Lynn and Dave Harris and Alex and Jocelyn, there's a cast of thousands again involved in this. And what we're trying to do is build up that next cohort of infection control practitioners and experts within BC. One of the great things that we did during the pandemic was we petitioned the ministry to give us funding so that we can deliver this content free for whoever wants to take it. And so that's being wildly successful. I don't know how much longer it'll last, but I think that's been very, very beneficial for the province. Now, just go to here. One of the big things that we have to do over the next few months is undo the doing. So to me, it's quite easy to develop guidelines and policy and doing so with our community of practice when we're talking about COVID in isolation. It's much more difficult now to take all the learnings that we had from COVID and then pull it back into some of our pre-pandemic, pre-COVID guidance. So that's going to be the work over the next several months. First off is going to be the viral respiratory infection outbreak guidance. So currently we have COVID outbreak guidance. We have to take that, merge it back with our old influenza and other respiratory illness work. And so all the IPAC medical directors and ops directors and public health and OC health will be working on this starting June through September. Invites should be in your inbox as of this actually a couple hours ago. We're also doing exactly the same thing for the acute long-term care guidance, visitation guidance. It goes on and on and on. So some of those 75 products we either have to retire and sunset, or we have to incorporate into our pre-pandemic guidance. So if you have a passion for guideline writing and development, let me or Linda know, and we'll get you to work. Oops, there you go. Let's pull this together. One of the other really exciting things is pulling together alongside the public health surveillance through BCCDC a coordinated provincial viral respiratory illness surveillance program. And this is going to be a collaborative process with all the health authorities and IPAC and micro, as well as epidemiology, so that we can make for priority setting decision making on a provincial level. Now I'll just skip through this. Here's just a logic model. And I'm just going to leave this here. I'm just skip through this. Just suffice it to say that we created a PPE, an ISO accredited PPE lab to ensure that the PPE coming in to the province was safe. And we also meet regularly for supply chain logistics. And we also helped out local industry to create more PPE so that we never have to rely on our colleagues to the south or internationally for PPE ever again. So if you're interested in this work, let me know. We're studying it. And the other piece, the final thing I forgot to mention, was learning from aerosols. And this is some of the work that Lynn Lee is doing on our previously named AGMP expert working group that we've now want to rename into an aerosol HVAC safety expert group. And Lynn could probably speak to it a little bit more than I, but the idea is instead of having a binary solution of is this something in AGMP or not, using a N95 yes or no, but really incorporating multiple factors, including the patient environment and patient disease, as well as the process. So I'm very excited for that work, and it'll be probably leading the country on some of that work. So hopefully we went through objectives. It was really fast, and not a tremendous amount of thanks to everybody who contributed to this presentation, and especially to everyone who has been working, being so dedicated to the pandemic response over the last couple of years. So I think we have a few minutes for questions, and I'll hand over to Dr. Gao and Jen in case she wants to thank anyone personally.
Thank you, Titus and Jen, for your very nice presentation. I want to give a shout out to the leadership and innovations of you guys have been done since COVID. Because of your work, the people at BC are receive this more accurate, rapid testing, and as a result, are better protected, and now receive more appropriate treatment afterwards. And there's a lot of innovations and works that you guys done. And show the strong leadership on the national and international level. Thank you all. And maybe I'll get people asking questions. So you can either raise your hands by reaction button or just speak. Yeah, any questions for Titus and Jen? I saw a few questions in the chat that's already been answered. Yeah, thank you. Yeah.
So Titus, are we going to meet and change the COVID outbreak guidelines to the respiratory illness guidelines?
Yes, we are. Absolutely. It's going to be the first one off, Susan. It's going to be me, you, Victor, and everyone else.
Boy.
Yeah, it's going to be fun.
Sounds fun.
So we do have an old document to work off of our PICNET viral illness outbreak guidance. I'm co-chairing this group with John Harding, one of our public health colleagues, and so we're going to take all the learnings that we had in the past 2 years and apply it to our previous guidance. And this will be I think this will be the prototype of the merged recommendations moving forward. So fingers crossed, it'll be okay. Clear as mud.
Other questions?